Good day. I'm pleased to share with you WHO perspectives on mental health and psychosocial well-being in emergency settings with an emphasis on disaster risk reduction. I will be focusing mainly on major emergencies. I think most of us will know what we mean with that, but to be clear, I'm talking about natural disasters, major industrial accidents, conflict. These are situations in which people's lives and dignity are threatened, and some form of outside help is usually requested. There are a range of global policies and resources that are relevant. There's the Sphere Handbook, which provides minimum standards for disaster response. It's globally the most widely used handbook for disaster response. There's Interagency Standing Committee IASC Guidelines for mental health and psychosocial support. There is the WHO's Mental Health Global Action Plan, which is endorsed by all member states. WHO, all ministries of health of the world have endorsed that, and which is in line with the previous named Sphere and IASC guidelines. And there is the MHPSS program of WHO, which is about integrating mental health in general healthcare, which is very relevant also in emergencies. Now, emergencies don't happen in a vacuum. When you are thinking of preparing for an emergency, we need to think that any community will have people with social problems. Let's think of marginalized groups, unemployment. Any community will have people with psychiatric problems. So that's the context in which disasters happen. Then emergency will induce new problems, new social problems, and often new psychiatric problems such as depression, post-traumatic stress disorder, alcohol use disorders. But it will also induce psychological problems that may look like psychiatric problems, but they are not. For example, people may be extremely scared, but it may be realistic fear, like they may be afraid how they will handle their future because they have lost their income. The basis of most international work on mental health and psychosocial support in emergency settings is the Interagency Standing Committee Guidelines, which enables coordination and identifies useful practices and flags harmful practices. It also gives definition of mental health and psychosocial support, a very inclusive definition which covers protecting or promoting psychosocial well-being and preventing and treating mental disorder. The most well-known slide out of the IASC guidelines, most well-known image is this image, which shows that different services that need to be made available are complementary to each other. We did a search to find out what people are actually doing, which we published in the Lancet in 2011, and we found that basic counseling is the most common intervention that's offered in emergency settings. Facilitating support for vulnerable individuals, let's say the social work type of interventions, for the second most common. Child-friendly spaces, number 3. Supporting community-initiated supports, number 4. And groups and families counseling, number 5. Now, before we get into DRR, disaster risk reduction, I'll just quickly outline what the Sphere Handbook suggests of what should be done in an emergency for mental health in the health sector. This is identifying, assessing needs and resources, enabling community members, including marginalized people, to strengthen community self-help and social support. The third one is psychological first aid, making sure that people can provide that to other people who are in acute distress. Number 4 is the care of people with severe mental health problems, mental disorders. It suggests that every health service should at least have one staff member that can provide care for these problems. And then the 5th point is often forgotten, is the safety, basic needs and rights of people with mental health problems in institutions. Let me just bring this to reality. We've seen disasters in recent years in Japan, in America, in New Orleans, in different places, and we've seen it in poor countries and rich countries. And in many of these places, people, institutions have not gotten enough attention, have been hurt in crisis, unnecessarily so, because they were ignored and forgotten. And the last point that is in the Sphere Handbook is to use disaster for building back better, which is also a key term in DRR, disaster risk reduction. So disaster risk reduction is a complex concept, but key elements of it are prevention and preparedness. Here are two documents that are really relevant to disaster risk reduction and the topic of this speech, which is the guidance note on disability and emergency risk management for health, which was WHO, UNICEF, and also UNISDR as part of this document, and a specific note on mental health and psychosocial support from a disaster risk management perspective, also with WHO and UNISDR. Now I would like to cover some of the main challenges of including mental health and psychosocial support in disaster risk reduction. First of all, as a mental health person, I have to look at my own field and say that the term mental health causes a lot of confusion. That's because we as a field use this term in different ways, and this causes confusion. So mental health is used when we talk about addressing mental disability. Mental health is used also when we talk about improving psychological resilience and well-being. And even some of us use the term mental health when we talk about improving social well-being. Now all these meanings are important, but they involve different actions. And it's a lot to ask of the emergency, of the DRR colleagues to understand the finer points of how we use these terms. It's not surprising then that because that mental health is not sufficiently on the development agenda, there's many reasons for that, but one of the key reasons includes our own use of language and our own conceptual complexities that the mental health field has. Stigma is an important reason. We know stigma is something that makes it more difficult for including mental health on the development agenda. We know that many countries have invested little in mental health so far, and as a result there's low existing baseline capacities. Moreover, when there are capacities, there's often a separation between what's done in the mental health system and in the emergency system, so that there's not enough synergies between the two in terms of developing mental health support that can be useful in emergencies. Now, what needs to be done? First of all, mental health needs to be given political priority, without a doubt. This is slowly coming on more and more over the years, but still much more needs to be done. We also need to we cheerlead our disability colleagues who are a strong community doing a lot of good things, but we wish they would give more attention also to mental disability. And in terms of preparedness, we think there's a number of things that need to be done. Decision makers, let's say mayors, people who are mayors or district leaders who are responsible for emergency responses, they need to know what to do for mental health. And they need to know it before there is an emergency. So we need to orient our decision makers in what to do. And that includes some very basic general things that decision makers have an influence on, like informing the population what's going on during a disaster, making sure that if there is displacement, keeping people together, looking after, checking how people are doing in institutions. Another thing to be done for disaster preparedness is to make sure that when capacity mapping is done, which is often done as part of development, that an emergency preparedness element is included. And during disasters, we know that capacity mapping is really important to see what services are still functioning, which ones are not, what are the resources in the community after the disaster. But before the disaster, we can build capacity for these assessments to be done well. Similarly, for psychological first aid, which is a very basic intervention, can be learned in half a day, can be offered by teachers, by health staff, by any key person in the community. Now, we don't think it's realistic to train everybody up in psychological first aid at any given time, just waiting for maybe one day a disaster will strike. But we could have training teams that are ready to train others on psychological first aid. So that could be part of preparedness. In terms of indicators, well, mental health needs to be part of DR policy without a doubt. But not only does mental health need to be named and included, in addition, we need to make sure that the whole DNR world moves a bit. It's more inclusive of the software. Right now, it's very hardware focused. Making sure there's helicopters, making sure water and sanitation is done well. But these people-centered approaches need to take a bigger place in DRR, and that will also make it easier for including mental health. Now, in terms of the indicators at the national, subnational level, we want to make sure that decision makers are trained in what key actions to do for mental health and psychosocial support. We need to create capacity so people can map capacities during emergencies. We need to create the capacity so people can orient psychological first aid where it's needed in emergencies. Now, a big concept in disaster risk reduction is building back better. We believe that in mental health has very good examples of building back better. We published a book last year on this with cases from these 10 settings, and this is something probably where other areas can actually learn from us. So building back better is possible in mental health because the interest in mental health is usually not that high, except after an emergency. Let me conclude now. First of all, to thank the inviters for letting me speak, and just giving a few key messages. First of all, mental health and psychosocial needs after disaster and conflict are very high. These needs are often ignored. Clear guidelines and technical instruments are available. The response can be largely delivered by non-specialist workers. Emergencies are an opportunity for mental health system reform. And on a more personal note, I would say if you do this work, if you work in emergencies or are about to work in emergencies, do take care of yourself. You need to model to others that mental health is important. Thank you very much.